like to talk to you about genotype 3. I come from a land down under, according to a certain song. And the context of hepatitis C treatment has changed dramatically, and it's important that you know that for the cases that I'm going to discuss. So up until a month ago, we had no access at all to antiviral therapy, except on compassionate use programs, DAA therapy, that is. But we went from being the worst health system in the world in terms of treating hepatitis C on March the 1st to the best. So we have access, all our patients have access to DAA therapy, care of a federally funded scheme. There are no barriers to treatment, and all it costs is a treatment of $37 per month for your pharmacy fee. And if you're on national benefits or anything like that, it costs you $5. So we can treat everybody, but I'm going to give you an experience where we couldn't do that. So I'm going to talk to you briefly about 3 cases. This first one is a patient of my colleague Simon Strasser's, who's with us today. It's a genotype 3, they're all genotype 3 cases, a 44-year-old man with genotype 3. He had a Meld of 20, Child-Pugh score of 11, and was on the liver transplant waiting list. He had ascites with weekly large volume paracentesis and spontaneous bacterial peritonitis episodes. Our compassionate use program, which started in, I think, about October 2014, was sofosbuvir plus declatosphere for 24 weeks without ribavirin in advanced liver disease with MELs greater than 15 or greater than equal to 15, and I'll show you that data at the end. So the patient's albumin improves because they're getting albumin infusions, and the Meld comes down to 17 by week 16 on therapy. However, despite biochemical improvement, there's episodes of hepatic encephalopathy, nausea and vomiting, hepatic hydrothorax, he's still having weekly paracentesis, remained prioritized for liver transplantation, and underwent successful liver transplantation at week 16 on treatment. Treatment was then continued to week 24, that's from the beginning of treatment, so another 8 weeks post-transplant, and the patient has got an SVR and is doing well 12 months post-transplant. So this is happy ending, but still requiring transplantation. The next patient is a patient of mine who's a 51-year-old, genotype 3. His Meld was 18. He was on the waiting list largely because he had enormous ascites. This isn't his large umbilical hernia, but it was something like that, let me tell you. He was treated once again with our compassionate use program. His Meld came down to 14 at week 24. And he didn't get transplanted because his Meld was essentially falling and couldn't get any priority for transplant. He had an SVR, but was still requiring TAPS every second week, and the main issue essentially was the huge umbilical hernia, not dissimilar to the one I just showed you. And the surgeons wouldn't go anywhere near him. It was a terrible situation for him with the quality of life, because unless the ascites could disappear, because of the recurrence of the hernia was considerable. We considered doing a TIPS because his Meld was down to 14, but we ummed and ahed, and while we were umming and ahhing, time went on, and 8 months post-SVR, his Meld was actually down to 12. He no longer had ascites, so therefore he could get his hernia fixed, and the surgeons did that. And 2 weeks ago, he underwent successful hernia repair. So we've gone from a happy ending to a very happy ending. And the last patient is a patient of mine with a 46-year-old man, Meld 18, the same issue, ascites, weekly large volume paracentesis, Child-Pugh 10, treated once again, and his Meld once again improved, but he had still requiring TAPS. He had virologic relapse at 3 months post end of treatment. His ascites was less and his Meld was stable, and he underwent 6 months surveillance of his CT scan, which had been going on during his time. I'd looked after him during that time, and he had sorry, it was a 2 to 3 centimetre, it wasn't a 23 centimetre, it was a 2 to 3 centimetre central hepatocellular cancer, which underwent TACE therapy, but on follow-up CT scan, he had progressive HCC with vascular invasion. He was now outside liver transplant criteria, and he developed progressive jaundice with bile duct obstruction, ascites, and the hepatorenal syndrome, and died 8 months post-relapse. So not so happy ending. So these 3 patients come from a large experience of what we called the TOSCA study, where I said that we didn't have access to antiviral therapy. And when patients with greater than, we thought that the patients that we needed to get treated were patients with MELDs greater than or equal to 15. We decided to use sulfan-DAC because we couldn't get access to Harvoni, and we didn't use ribavirin because the reason we didn't use ribavirin was that we thought these patients would be sick. They would require a lot more monitoring if they were on ribavirin, and we didn't have any funding to actually look after the patients. We had funding to collect the data, but we had no increased funding to look after the patients. So we thought the minimal effect on our clinical care would be to give them sulfan-DAC. So this shows you that this is 111 patients. Over 400 have been treated, but I'm just going to show you data on 111 who have reached the 12-week post end of treatment data. So Australia is quite unique, but not totally unique. There are areas in Asia with lots of genotype 3. So 46% of our patients had genotype 3. Which is shown. So 46, this is the patients, most of them were male. Sorry? Oh, yeah. Good thinking. Good thinking, 99. You can see it better now.
It works better that way.
It works better that way. 46, so 51 patients with follow-up with genotype 3. So it's just to reassure you that all these patients do have MELD scores greater than 15, so it's not contaminated by patients with lower MELD scores, which the SOLAR studies are, although you can split them based on MELD. The mean MELD was 17, the mean Charles Pugh score was 10, with a small number of patients in B8, B7 to B9. 77% of them have ascites and 61% have encephalopathy. So I think you can get the picture that this is quite a significantly advanced group of patients. This is what happened to their biochemical response, and it comes back to this MELD of around about 20. So 3 out of the 6, this was just the small number that had been followed up at this point. We had improvement of MELDs greater than 2 improved, but they improved to a MELD of less than 20 but not less than 15. So we sort of had a bit of a concept that MELD 15 in Australia is a sort of time to think about transplant if you don't have other complications, and sure you can get transplanted less than that because with ascites and et cetera, but MELD 15 we thought was sort of a bit of a transplant cutoff when used by itself. So 62% of MELDs less than 20 improved by greater than or equal to 2 points, and 50% all ended up with a MELD less than 15, and all of those had a MELD less than 20 to start with. So you could argue that this 50% of these were actually in the category now of not having a transplant benefit in the short term based on the data from the United States. It does beg the question, however, is a MELD of 14, right, if you get there because you went from MELD 9, 10, 12 to 14, does it have the same prognostic implications as if you've got a MELD of 14 when you started with a MELD of 19 and went 19, 16, 14? We don't know that. The prognosis analysis based on MELD, I think, are mostly assumed to be due to MELDs. You're getting there by you're increasing MELD, not by decreasing your MELD. That's an interesting point to discuss, perhaps. So this is the data, this is the treatment response. We had 51 genotype 3 patients. We've got follow-up at week 36, that is 12 weeks post end of treatment in 46. 4 out of the 46 had breakthrough, and 8 of the 46 had relapse. So essentially, we have a 26% failure rate for genotype 3 advanced disease with an SVR of only 74%, using SOF and DAC for 24 weeks, not 12 weeks, and without ribavirin. We've now switched, based on this, to using 24 weeks with ribavirin, but we don't have the data yet. Interestingly, I did this analysis a bit like Kosh early this morning, that previous pegylated interferon or no previous pegylated interferon really did not predict whether you were going to have a treatment failure. We had 3 deaths at 1, 2, and 5 months on treatment. 11 patients were transplanted, 5 following treatment, and 2 of those were virological relapses. I think 1 was a relapse and 1 was a viral breakthrough. The 6 patients who were transplanted on treatment continued treatment post-transplant and are all now PCR negative. So it begs the question now: is all this irrelevant in the world of sofosbuvir and velpatasvir instead of sofosbuvir and declatosphere? And I'm not too sure that the data is not going to apply to this group to genotype 3. This with this regime as well. This is the data, and the impressive data is, of course, sofosbuvir, velpatasvir, and ribavirin for 12 weeks with an 85% SVR. So in this group, if you did what we did, which was sofosbuvir, declatosphere without ribavirin, then your results are 50% SVR, which are actually less than what we're seeing in our group of patients. However, you have, as Nora's pointed out, all these studies have relatively low numbers of patients, although this is, 75 is quite a lot for decompensated disease. But I think some of this data is a combination of B and C, and not all their Meld scores were greater than 15. So I think the patients that we are studying have more advanced disease generally than this group of patients. But you can see in principle the error bars are huge. So you actually don't know whether this 85% represents something around about 50 to 55%, or in fact 90%. You don't know that. The error bars are too big. So I think treatment failure for very advanced decompensated disease with sofosbuvir and velpatasvir may still be an issue. So what are we doing now with our patients? We would recommend now SOF and DAC and RIBA for 24 weeks with decompensated experienced G3s. Like everybody, we sort of moving all the time on this. Our Melds less than 20 we're treating. We're treating everybody if they're not going to go to transplantation. But if they're going to transplantation, their Melds at 20 we're treating. If they get an SVR of less than 15, then there's an issue of whether there is a transplant benefit anymore, and perhaps they should be removed from the waiting list. If, however, they've got lots of tensitis and hepatic encephalopathy, they'll still require a transplantation. Melds greater than 25 we're not treating with genotype 3. We would transplant and we would treat post-transplant. And although there's very little data on genotype 3 treatment post-transplant, by the way, we would predict with minimal fibrosis that we get excellent SVRs. Now, this group between Meld and 25, where is the cutoff? I think what we're doing, I'm not sure what we're doing, but I think what we're doing is if the patient's likely to be treated within 6 months, then they're likely to get transplanted on treatment, have treatment continued, and they're likely to get an SVR. While if they're not likely to be transplanted within 6 months, then we wouldn't treat them, because we know that essentially they're going to have a 26% relapse or virological breakthrough rate. This could come from this group or this group. And then they're going to be transplanted essentially with NS5A resistant virus. And they're going to have universal recurrence. And then what are we going to do? We're going to treat NS5A resistant virus. And I don't know that there's any data that velpatasvir treats declatosphere NS5A resistance. People in the room may have that data. If you use velpatasvir in this situation, then this may be as low as 15%, right? But it could be higher. You're still going to have this problem, and then you're certainly going to have NS5A resistance related to velpatasvir. And at the moment, before transplant, you can't treat those patients. So I think the questions for decompensated G3, whether treatment experienced or not, is I would think that I would support Nora's concept. I think we need to use ribavirin in these decompensated patients. Whether we need to treat for 24 weeks would be really interesting to know the velpatasvir data with ribavirin treated for 24 weeks, whether the SVR rates could get above an average of 85%, although it's, as I said, the error bars are high. So will the sofosbuvir and velpatasvir results be better? I think so, but we're still going to have from the data 15 to 25% NS5A resistance. And what are we going to do then? Will velpatasvir treat DAC-induced NS5A resistance? We would need soft DAC and a PI, and we could use that post-transplant, but you can't use it pre-transplant because at the moment protease inhibitors are contraindicated in decompensated disease, and there's no reason to think that the new protease inhibitors will be an exception to that. So although hepatitis C is incredibly boring these days, and everybody gets writer's cramp, I think a genotype 3 decompensated disease is still going to leave us with lots of challenges, and that's what we're here for. Thanks very much.